because today we've got a big topic to cover, so we're gonna need all those the 2 hours we've got. So, hello again, my dear future doctors. Welcome to our tutorial. Today we're gonna talk about one of my most favorite topics. That is drugs that affect central nervous system. And we're gonna cover just a first part of it. It is chapter 9 in your books, aka the Pharmacology for the Dentists. And we're gonna cover sedative hypnotics. We're gonna cover alcohol or ethanol, as well as anti-epileptics and anti-Parkinson drugs that are used to treat Parkinson's disease. Okay, so we have a lot to do, and I'm not gonna waste any more of your time. I'm gonna just jump to the subject. Yeah. I promise this is gonna be interesting, but difficult as well. Yeah. Okay, let's start that. Oh, hello, Sarah. How are you? Yeah. Okay, I hope you're seeing. Guess you are. Okay, this is me again, and today we're going to talk about drugs affecting the central nervous system. Okay, we discussed autonomic nervous system, but now logically what's left to discuss is central nervous system. So first, before we're going to jump to directly to the drugs, I wanted to talk about with a few words about neurotransmission in the central nervous system. So as you can imagine, the circuitry of the CNS is much more complex than that was with the autonomic nervous system, because we've got more neurotransmitters, a lot of synapses. So number of synapses in the CNS is far greater than ANS. They contain powerful networks, not just excitatory neurons, but as well as inhibitory neurons that are constantly active and modulating the rate of the neuronal transmission. And CNS communicates through use of more than 10, approximately 50 types of neurotransmitters, while in ANS we just discussed acetylcholine, noradrenaline, and adrenaline. Okay, there are a lot of more neurotransmitters in the CNS, and receptors at the most synapses are coupled to the ion channel. So you can imagine they are really fast and active. So now let's talk about the excitatory pathways before we go to inhibitory ones. So these are, as you can understand from the title, that cause excitement or excitatory postsynaptic potentials. So the stimulation of excitatory neurons causes the movement of ions that result in depolarization, okay, of the postsynaptic membrane. And stimulation of the excitatory neuron causes the release of transmitter molecules such as glutamate and acetylcholine. Those are excitatory neurotransmitters, which bind to the receptors of the postsynaptic cell membrane, and this causes transient increase in the permeability of the sodium channel. So sodium enters the cell, we've got the depolarization, okay? And the influx of the sodium causes a weak depolarization, or EPSP. It means excitatory postsynaptic potential, okay? That moves the postsynaptic potential towards its firing threshold. So we've got excitement of all the depolarization, excitement of the receptors, and all or non-action potential that is called. And now let's talk about, yeah, you can see here excitatory glutamate or acetylcholine, which are excitatory neurotransmissions. You can see they are released from their vesicles. They are in the synaptic cleft, and excitatory potential occurs. Okay, this is how it looks like. This is the neuron, which is composed with the body neuronal body axon, the longer one covered with the myelin sheet, and dendrites which are connecting them with each other. Okay, signal transmission through the synapses. Okay, this is how it looks like. Now, this is excitatory neurotransmission, for example, with the glutamate. You can see here excitatory potential, and sodium channels open, sodium enters the cell. So plus charged ions enter, it means depolarization occurs and action potential will go to. Now let's talk about inhibitory pathways. So the stimulation of inhibitory neurons causes movement of ions that result in hyperpolarization of postsynaptic membrane. And which are the ions? They will be negatively charged chloride ions, okay? Stimulation of inhibitory neurons releases neurotransmitter molecules such as alpha, gamma aminobutyric acid, or GABA, as we all know. This is GABA is inhibitory neurotransmitter, as well with the glycine, okay? We had glutamate and acetylcholine in excitatory pathways, and we've got gamma aminobutyric acid, or GABA, and glycine in the inhibitory pathway. They bind the receptors of the postsynaptic cell membrane as well as all the other neurotransmitters. This causes increase in permeability of the potassium and chloride ions, okay? And the influx of negatively charged chloride ions and efflux of the positively charged potassium causes a weak hyperpolarization, and it means IPSP occurs. It means inhibitory postsynaptic potential that moves the postsynaptic potential away from its firing threshold. It means inhibition occurs. So this is how it looks like with the comparison of the excitatory and the inhibitory synapses. We've got glutamate here, we've got GABA here, sodium influx that causes depolarization, while chloride influx causes hyperpolarization. Okay, this is how it looks like, and so we know that there are two ways, inhibitory and excitatory, but that doesn't mean that neurons only just act as excitatory pathway or inhibitory. Those are combined effects, okay? Most of the neurons in the central nervous system receive both excitatory as well as inhibitory postsynaptic potential input. So this is how it looks like. And this was all the preview to the drugs, and now let's start with the sedative hypnotic drugs. Okay, sedatives, how you understand, those are the drugs that subdues excitement and calms the subject without inducing sleep. It means without sleep. Okay, through drowsiness may be produced. Okay, and sedation refers to decreased responsiveness to any level of stimulation, and it is associated with some decrease in motor activity as well as ideation. Okay, so sedation, it means the decrease in excitement, calming the subject without inducing sleep, but inducing drowsiness, and motor activity as are decreased and ideation is decreased. While hypnotics, what are they? Those are the drugs that induce or maintain sleep, similar to the normal arousable sleep. Okay, normal sleep. You shouldn't confuse it with the term hypnosis, which is a trance-like state in which subject becomes passive and highly suggestible. So this is just the normal sleep, okay, not hypnotic state or trance-like states. So now first drugs that are described as Sedative hypnotics are barbiturates, the biggest, not one of the biggest group of the drugs. They induce tolerance as well. They also drug metabolizing enzymes are activated, and they cause physical dependence with the long-term usage because and the cessation of the barbiturates abruptly causes severe withdrawal symptoms, and they also have the ability to cause coma or its high doses. It's a toxic doses as well. So what is the mechanism of their action? As you can understand, sedatives and hypnotics, all of them activate inhibitory pathway. It means they are GABA linked, right? Interaction with the gamma-aminobutyric acid 8 type receptors, they enhance GABAergic transmission. It means they enhance inhibitory transmission, and the binding site is distinct. Prolong the with the GABA, and prolong the duration of the chloride channel opening. It means they can block citric glutamate receptors as well. So anesthetic concentration of the pentobarbital, which is the example of the barbiturates, also block high frequency sodium channels. It means they lead to decreased neuronal activity. That's why they cause sedation and even sleep or hypnotics that way. And now let's start with the examples. First one will be thiopentol sod, which you have discussed with anesthetics. They act within seconds and has a duration of action about 30 minutes. It means half hour. It is used as an intravenous induction of anesthesia, as we have said before. And another agent will be phenobarbital, also well-known one. It has a duration of action greater than a day, so it is possible to give as a medication once in 24 hours, or daily dose will be one. Treatment of the seizures, and especially with the children. So the children are very, let's say, exquisite types of patients, so we cannot use all types of medication. But the phenobarbital is one of the medication we can use for the seizures, for the epilepsy, to treat those seizures. Okay. And we've got secobarbital and amobarbital. They are both of them are short-acting barbiturates and effective as well as sedative, as well also hypnotic drugs. Okay, they cause not just sedation but also the sleep. Okay, but they are not anti-anxiety agents. Anti-anxiety we will discuss them later. Okay, but not in this lecture. So, what are the actions that barbiturates exhibit? For the first one, logically, depression of the central nervous system. So, at low doses, the barbiturates produce sedation. This is the wanted effect one. At higher doses, the drug causes hypnosis. It means induces sleep, and followed by anesthesia. Okay, loss of consciousness as well. And finally, at higher doses or toxic doses, it might cause coma and even death. So it all depends on the dose. They don't raise the pain threshold. They have no analgesic properties. So the use of for anesthesia, the solely use of for the anesthetic measures, it is not recommended because they have no analgesic properties, so they don't numb the pain. So chronic use as well, we have mentioned this one. It leads to tolerance. Okay, chronic use. So what I mean by that. So the second action will be respiratory depression. So this is the reason of the coma and death. Usually, they suppress the hypoxic and chemoreceptor response to CO2. It means the CO2 signals our body, our breath tunnel, which is located in our medulla oblongata, that we've got to breathe. Okay, if we don't detect the collection of CO2, we might as well see breathing. So the overdosage causes the respiratory depression and death, and the mechanism is the following: because chemoreceptor response to carbon dioxide is suppressed. Okay. And enzyme induction, they induce cytochrome P400 50 system macrosomal enzymes in the liver. So it means that they can interact with a lot of drugs. So chronic barbiturate administration diminishes the action of many drugs that are dependent on this cytochrome P450 metabolism to reduce their concentration. Okay. So these were examples of interactions. Now let's talk about therapeutic uses. We have said that they are a group of sedative hypnotics, but they can be used as well for the anesthesia because they are ultra short acting barbiturates such as thiopental is used IV to induce an anesthesia. Okay. And anticonvulsants, we said in the children, phenobarbital is very widely used. It's used as in long-term management of the tonic-clonic seizures, as well as status epilepticus. It means the seizures, in between the seizures, the patient does not regain consciousness. So this lasts more than just a single seizure. Okay. And eclampsia. Eclampsia is the state in the pregnant woman which will cause hypertension. Okay. Preeclampsia, eclampsia, you will start in this one in obstructive. Okay. The treatment of young children with the recurrent febrile seizures. What that mean? Most children, thermoregulatory system as well as the brain is not formed well, so it is very naive and very prone to seizures, if I can express like this. So even the raise in the temperature of the febrile, it means more than a 38 degree of Celsius or more than that, this can induce seizures in the children. So phenobarbital can be useful with the febrile seizures as well. So they can suppress cognitive performance in the children, obviously, as any of the epileptics can do, and specific anticonvulsant activity they have with the children. Okay, and anxiety. We said that mild sedatives are used to relieve anxiety as well, and also nervous tension and insomnia. It means sleep disorders can be resolved with the usage of the barbiturates, but they cause tolerance and dependence as well. Suppress the REM sleep more than other stages. And lastly, they have been replaced by benzodiazepines, which we'll discuss for that. So now let's talk shortly about pharmacokinetics, which is as well important, and you will read it in the book. So they are absorbed orally and distributed widely throughout the body. They are redistributed in the body because they happen to go in the brain for the most part of it, and from the brain they are redistributed to the skeletal muscle and finally to the adipose tissues. This movement is important in causing the short duration of action of the thiopental and similar short-acting derivatives as well. They cross the placenta barrier. It means blood-porous placenta barrier is like crossed by barbiturates, and they can depress the fetus. So they are really dangerous with a pregnant patient. Okay, be careful with that. And they are metabolized in the liver. We mentioned cytochrome P450, and they inactivate metabolites are excreted through the urine, through the kidneys. Now let's talk about adverse effects. So obviously they cause drowsiness, impaired concentration, mental and physical sluggishness. This is the normal thing for the sedative hypnotics. And hangover is common, drug hangover. It is the feeling of tiredness well after the patient wakes. So in the morning, you normally should feel relaxed and regain your energy. But those patients who are on treatment of barbiturates, they feel tired when they are waking up. The impaired ability to function normally for many hours after after waking, and occasionally nausea and dizziness might occur. So, what are the precautions for the prescription of the barbiturates? We should know that they decrease the duration of action of the drugs that are metabolized by cytochrome P140, 450, and they increase porphyrin synthesis, which is important for the patients who are diseased with acute intermittent porphyria. It is the severe blood condition, which if you're interested, you can Google and read it. It's contraindicated with these patients, okay, because it can become even more severe than it is already. And they cause not just tolerance, but also physical dependence. So abrupt withdrawal causes tremors, anxiety, weakness, restlessness, nausea, and vomiting, even seizures and delirium can be caused, and also severe cardiac arrest. So withdrawal associated with opiates and also this barbiturates can result in a death. So that is why the dosage should be step by step lowered and then ceased. Okay. And the poisoning and the toxic doses, we said that they cause all these adverse effects, but poisoning or drug overdose can cause severe depression of the respiration through, again, chemoreception to the carbon dioxide is decreased, central cardiovascular depression as well, shock-like condition with shallow infrequent breathing can occur. And treatment includes artificial respiration or mechanical ventilation, and as well purging stomach of its contents. I mean, barbiturates are often used as a tool for suicide. So what are the steps we're going to perform if the patient has overdosed with the barbiturates? We're going to if we need, we can put them on mechanical ventilation, then purge the stomach when inserting as a gastro tube and lavage fluid or contents should be evacuated. If the drug has been recently taken, if it's already in the blood, rinsing the stomach will not be effective. So no specific antagonist will have, so no antidote actually will go. So we can use hemodialysis if we've got large quantities that have been taken, and also alkalization of the urine can help to for excretion and elimination through the kidneys. Okay, and hemodialysis, it's extracorporeal detoxification. It means we join the patient with an apparatus or the machine that clear the blood, and clean blood returns to the patient. Okay, these will all barbiturates, and we said that they are highly replaced with the benzodiazepines, and benzodiazepines are the ones that we're going to discuss now. Is everything clear to you here? Can you tell me?
Yes, yes.
Okay, thank you. Thank you. Oh, you said this one. Okay. Go on then. So benzodiazepines or BZDs, as we gonna meet in the literature, they are the targets for benzodiazepine actions are the as well as the gamma aminobutyric acid receptors, GABA A receptors. The binding sites are labeled as BZ1 and BZ2 benzodiazepine receptors, so different sites than barbiturates. Benzodiazepines increase the frequency of the channel openings produced by GABA, so they enhance inhibitory pathway. The influx of the chloride ion causes a small hyperpolarization, and that moves the positron potential away from its firing threshold and inhibits the formation of action potentials. Okay, then binding of the benzodiazepines to its receptor site will increase the affinity of GABA for the GABA binding site without actually changing the total number of the sites. Okay, Just the binding effect will be, affinity will be changed. Okay, this is GABAergic hyperpolarization, known slide as well. And now let's talk about the mechanism and the actions. So neither antipsychotic activity nor analgesic action they have, but they also do not affect the autonomic nervous system, but they affect CNS, obviously. They reduce anxiety, so they can be used as anti-anxiety drugs. They selectively enhance GABAergic transmission and inhibit neuronal circuits and the limbic central system of the brain. And they can be used as a sedative and hypnotic actions. Obviously, they're through mediation of the GABA receptors, and they can cause anterograde amnesia. What is it's the ability to learn and form new memories is lost. Okay, anterograde means after that new things. To learn and form new memories is lost with the usage of the benzodiazepines, and they can be used as anticonvulsants as well, because also inhibitory pathways mediated through GABA, and can be used as muscle relaxant. This is the difference as well. They increase persinetin inhibition in the spinal cord, not just in the brain, but in the spinal cord as well. So they cause muscle relaxation as well. So now let's talk more about benzodiazepines. They are reserved for the continued severe anxiety, and then should only be used for the short period of time because they might cause addiction. Okay, addiction is very common with the uses of the benzodiazepines. The longer-acting agents, which are clonazepam, lorazepam, and diazepam, those are for the patients with anxiety who may require treatment for prolonged periods of the time. And anti-anxiety effects of the benzodiazepine are less subject to tolerance than the sedative and hypnotic effects. So the tolerance occurs when we use these drugs more than 2 weeks. 1 to 2 weeks can occur the tolerance. And they have also cross tolerance with ethanol, so among the group of agents with ethanol. So those who were on benzodiazepines might develop tolerance on ethanol as well. It is been shown that tolerance is associated with the decrease in GABA receptor density. Okay, they decrease. This is the mechanism of the development of the tolerance. And also they are used for the panic disorders, for example, like alprazolam is effective for short and long-term treatment, as well as it may cause withdrawal reactions in 30% of the sufferers as well. So this is important consideration. Now let's talk. We have already partially discussed therapeutic uses, but widely let's do muscle disorders, because they cause muscle relaxation because they have the effect on the spinal cord. For example, diazepam is useful in the treatment of skeletal muscle spasms or muscle strain, and the treatment of spasticity during multiple sclerosis or even cerebral palsy. And they can cause anterograde amnesia. They short-acting agents like for example midazolam, they are often employed for pre-medication or pre-anesthetic or pre-surgical medication for the anxiety-provoking or unpleasant procedures like endoscopic, bronchoscopic, colonoscopic, and certain dental procedures, as well as angioplasty. They cause conscious sedation. It means the patient is aware of what is happening, is responsive but still sedated, calm, and not protesting or not acting against the procedure. So this is the form of midazolam. It is a benzodiazepine also used for induction of anesthesia as well. Now, another therapeutic uses, they are used for the seizures as anti-epileptics, for example, clonazepam for certain types of epilepsy, and diazepam and lorazepam are drugs of choice in termination grand mal, it means generalized tonic-clonic seizures, and also status epilepticus, which I said it has many seizures and the frequency in between the seizures, person does not regain consciousness. They also, as I said, have cross tolerance with chlordiapixodine, chlorazepate, diazepam, and oxazepam, and also alcohol withdrawal and reducing the risk of withdrawal-related seizures is possible with the usage of the benzodiazepines. Now, they are useful as hypnotics or for the sleep disorders as well. But not all of them are useful as hypnotics. Also, all of them have sedative and calming effects. They decrease the latency of the sleep onset and increase stage 2 or non-rapid eye movement. It means REM sleep, okay? Both REM sleep and the slow wave sleep are decreased, and the treatment of insomnia is important to balance the sedative effect needed at a bedtime with the residual sedation. It means hangover upon awakening. So most of the patients, when I awaken in the morning, they feel tired. So we should, while prescribing, we should determine the dosage necessary just to improve the sleep, but not to cause hangover upon awakening. So, and long-acting flurazepam. We've got intermediate-acting temazepam and short-acting triazolam, which are used for the sleep disorders mainly. So flurazepam, temazepam, and triazolam, I have discussed them one by one, and you're gonna read them one by one and learn that. Okay. So hypnotics should be given for only a limited time. Okay. Usually less than 2 to 4 weeks, because again they might cause tolerance and addiction as well. So that is why, to avoid all those effects, we should use them for the short period of time. Now, shortly about absorption and distribution. They are lipophilic, it means they can easily cross the barriers. They can be absorbed after oral administration and distributed throughout the body. Duration is, we've got short, intermediate, and long-acting ones, and division by that we have discussed. And they are metabolized in the liver. They can cross the placental barrier and blood-brain barrier, and they have effect on the CNS, and they depress the CNS of the newborn or of the fetus as well. So while nursing infants dries in the breath because of the lipophilic properties, they can also happen to be in the milk of the mother. So while nursing, the effect milking through the milk, they can be transported to the newborn as well. So careful as well. Dependence, as I said, they cause physical as well as psychological dependence. So high doses, if they are given for a prolonged period of time, they might cause dependence. And abrupt discontinuation might cause withdrawal symptoms like confusion, anxiety, agitation, restlessness, insomnia, and tension, and rarely even seizures are possible to happen. And how they have long half-lives, means they have longer duration of action, and withdrawal symptoms may occur slowly and last number of days. Okay. And benzodiazepines with a short elimination half-life, such as triazolam, induce more abrupt and severe withdrawal reactions. So those who have long half-lives produce their effect at the last number of days, while short half-life ones have more abrupt and severe withdrawal reactions. Now, adverse effects include drowsiness, confusion, which are most common, and ataxia might occur. It means discoordination or imbalance, cognitive impairment or decreased long-term recall and retention of the new knowledge, or it means anterograde amnesia, forming new memories and new habits, and triazolam, which is might cause a rapid development of tolerance, which is short-acting one, and early in the morning insomnia, daytime anxiety, amnesia, and confusion as well. They should be used very cautiously in the treatment of patients with have impaired functions of liver and also with acute narrow angle glaucoma. So this is the consideration you should keep in mind. And also alcohol and the other CNS depressants enhance the sedative hypnotic effect of benzodiazepine. It means the people who are misusing or abusing alcohol or are prescribed other CNS depressants should be carefully prescribed with benzodiazepines because their effect can be enlarged by the usage of alcohol and CNS depressants. They are less dangerous. Drug overdose is seldom lethal, not like barbiturates, unless the other central depressants or alcohol is employed and taken concurrently. And as well with the barbiturate, as you said, they have no antagonist or no antidote, while with benzodiazepine we've got antagonist, which is flumazenil. Remember this one? This is often used in the ER or emergency department when you get a patient with a benzodiazepine overdose. This flumazenil is the GABA receptor antagonist that can rapidly reverse the actions of the benzodiazepines. So they are administered only intravenously because we want the immediate response, and the onset is rapid, but the duration is short. So half-life is about 1 hour, so we need the repeated administration as well. Frequent administration may be necessary to maintain a reversal of the long-acting benzodiazepine. So as well, you should keep in mind long-acting ones require more than one administration of flumazenil. Withdrawal is dependent on patient or the cause of seizures if the benzodiazepine is used to control seizure activity. And seizures are seized with the tricyclic antidepressants as well. And dizziness, nausea, vomiting, and agitation are the most common side effects of the flumazenil. So this is also what you should know. Now let's talk about non-benzodiazepine sedative hypnotics. The first one will be, these are new agents, newly discovered and developed drugs, which is zolpidem, the first one. It is acts on the subset of the benzodiazepine receptor family BZ1, but it has no anticonvulsant or muscle relaxing properties, just sedative hypnotic. Okay. They have fewer withdrawal effects and exhibit minimal rebound insomnia, and bitter or no tolerance occurs when we have long-term treatment. Okay, so those are pros for the usage of zolpidem. So they have minimal insomnia or awakening tiredness. They have no tolerance with the long-term usage, and but they have no anticonvulsant or muscle relaxing properties. They are rapidly absorbed from the gastrointestinal tract and has a rapid onset of action, short elimination, half-life amazed for 3 hours and eliminated from the body, and provides hypnotic effect approximately for 5 hours. So this is a good thing while taken before sleep to cause them to make it easier to fall asleep. Undergoes hepatic oxidation through site 450, so this rifampin, for example, the drug that also is metabolized by system, also induces site 450, shortens the half-life of the zolpidem. So this is really interesting. And the drug that inhibits cytochrome 450 system increase the half-life of the drug. Okay. So this is the indication as well in drug interaction. The side effects might be nightmares, agitation, headache in the morning, GI upsetting because they are most of them observed from the gastrointestinal tract, dizziness, and daytime drowsiness, but less common than with the usage of benzodiazepines. Zolpidem, Zaleplon, and Eszolpiclone, those are significantly altered various sleep stages and often they are preferred as hypnotics due to selectivity for the benzodiazepine 1 receptors. Okay. Now zolpidem we discussed. Now let's do Zaleplon and Eszolpiclone. I think you better read this one by yourself. Those have similar properties, but this one has a half-life approximately 1 hour, so short duration of action. And Epiclone is called Zopiclone, is also known as a hypnotic, effective for up to 6 months. Okay, they are rapidly absorbed, and elimination occurs within the 6 hours. Adverse effects include anxiety, dry mouth, headache, peripheral edema, somnolence, and unpleasant taste as well. And Ramoltone, this one is newest drug, also selective agonist of MT1 and 2, melatonin receptor 1 and 2. They have light stimulating the retina, so this is interesting. I think you're gonna like this part. So light stimulate the retina, transmits a signal to the suprachiasmatic nucleus, which is located in the brain and the hypothalamus, that releases signal via lengthy nerve pathway to the pineal gland that inhibits the release of melatonin from the gland. So as the darkness falls and the light ceases to obstruct the retina, melatonin release from the pineal gland is no longer inhibited. So but a lot of melatonin in the darkness. So the gland begins to secrete a lot of melatonin, and it induces and promotes sleep in the darkness. It maintains circadian rhythm underlying the normal sleep-wake cycle. And the treatment of insomnia in which falling asleep or increased sleep latency is primary complaint. Ramoltone is very useful for that. It can be administered long-term, and adverse effects include mild dizziness, fatigue, somnolence, which can be aim, and increased prolactin levels. You can say sometimes headache might occur for that. So this is a good thing you should know. Okay. Now some of the antihistamines, as we've discussed many times, they have sedative properties like diphenhydramine, doxazine, and doxazolamine. They're effective in treating mild types of insomnia, but side effects are anticholinergic effects, as we know. And now second, our topic will be ethanol, which I have very shortly discussed, and longer description you're going to read in the book. So ethanol, or alcohol, it has anxiolytic and sedative effects. Toxic potential overweights its benefits, so that is why it is not used for the medical purposes anymore. CNS depressant, it is a CNS depressant, a very potent one, produces sedation and hypnosis with increasing dosage, so dose-related depression of the CNS. It has a shallow dose response curve. It means the sedation occurs over wide dosage range. It is absorbed orally and has a voluminous distribution close to that of the total body water. So you can imagine how well it's distributed and dissolved throughout the body. It is metabolized primarily in the liver, first to acetaldehyde by alcohol dehydrogenase, which is the enzyme that metabolizes it, and then to acetyl by aldehyde dehydrogenase. So, and the different tolerance to ethanol in different populations depends on the different expression of those enzymes. Okay, elimination through the kidneys happens obviously, and the fraction is excreted through the lungs through the expiration as well. It synergizes with the sedative agents we've said before. They can produce severe CNS depression when used in a combination with benzodiazepines as well as antihistamine or barbiturates. That's why when the physician prescribes the benzodiazepines or antihistamines and barbiturates, advises and warns the patient not to drink or take any type of alcohol because CNS depression can be severe for that. Chronic consumption leads to severe liver disease as well as gastritis or inflammation of the mucus of the stomach, and a nutritional deficiency, which is a B6 vitamin deficiency as well, cardiomyopathy as well, and also alcohol withdrawal treatment. So benzodiazepines can be used for the alcohol withdrawal treatment because they can cause CNS depression and can be used for that. Carbamazepine is effective in the treating convulsive episodes during withdrawals as well. So there's white fever that is called with seizing or abstinence during the withdrawal from the alcohol can be managed with the use of benzodiazepines and carbamazepine as well. Now, drugs to treat alcohol dependence shortly, just one slide. The first one is disulfiram that blocks oxidation of acetaldehyde to acetic acid by inhibition of aldehyde dehydrogenase. It causes accumulation of acetaldehyde in the blood, causing flushing, tachycardia, means increased heart rate, hyperventilation, increased respiratory rate, and the nausea. So these are the malignant effects, malignant symptoms. So it abstains from alcohol to prevent the unpleasant effects of the disulfiram induced aldehyde accumulation. Next one will be naltrexone. Naltrexone or naloxone. This is the opioid antidote for the morphine toxic effects, morphine poisoning. Can be used as well with alcohol to treat alcohol dependence. They have long-acting opiate antagonists used with supportive psychotherapy. It is better tolerated than disulfiram and does not produce the aversive reactions like nausea, hyperventilation, tachycardia, flushing, and so on. And also acamprosate is a purely understood mechanism of action, but with a supportive psychotherapy also used to treat alcohol dependence. So is everything clear to you here, guys? Because I have some questions about this thing, okay? Are you? I showed you my answer. Sorry. So, Marilyn, are you with me? Can you read this question?
Yes. Which of the following statements is correct? Benzodiazepine Benzodiazepines show analgesic action.
No, we said
clinical improvement after anxiety requires 2 to 4 weeks of treatment with benzodiazepine. All benzodiazepines have some sedative effects.
Yes. Yes, they are system depressant, readily produce general anesthesia. No, all of them have the property of sedative effect, but not all of them are analgesic and not for anesthesia. Okay, so answer will be which one? Yes, you're right. Okay, the next one. Philip, can you read the next one? Anyone? Sarah, Yusuf?
Which one of the following is a short-acting hypnotic?
Hypnotic, yes. Short-acting. Okay, which one?
Phenobarbital, diazepam, chlordiazepidexide, trizolam, and flurazepam.
Okay, I will just give you the answer. Triazolam.
Okay.
Hypnotic. All of these are longer or intermediate ones. Do you remember, Yusuf? triazolam is a short-acting hypnotic. Okay.
Yes.
And the next one, Sarah, are you with me?
Yes, I'm here.
Okay,
Which
please.
one of the following statements is correct? Phenobarbital shows analgesic properties. Diazepam and phenobarbital induce the cytochrome P450 enzyme system. Phenobarbital is useful in the treatment of acute intermittent
Okay, we
porphyria.
said that this is contraindicated. We said like.
Phenobarbital induces respiratory depression, which is enhanced by the consumption of ethanol. Buspirone has actions similar to those of the benzodiazepines.
Okay, I will not torture you. So this one is the true answer. So it induces respiratory depression, which is enhanced by consumption of the alcohol. Okay, so this one was the correct thing. So the next one, who wants to read it? No
A
one?
45 years old man who has been injured in a car accident is brought into the emergency room. His blood alcohol level on admission is 275 milligram per deciliter. Hospital records show a prior hospitalization for alcohol-related seizures.
Yeah.
His wife
Seizures.
confirms seizures. His wife confirms that he has been drinking heavily for the past 3 weeks. What treatment should be provided to the patient if he goes into withdrawal?
Withdrawal. Yeah. We said this one. Yeah. Lorazepam is very effective for the withdrawal related with alcohol. Okay, and seizures as well. Okay, remember this one, Yusuf, as well. So a lot to remember, and I know, but it's quite good. So I will give you 5-minute break, and we will go to. We have two more topics: Parkinsonian drugs and anti-epileptic drugs. Okay. So I will give you 5-minute break. Is it okay with you? So someone has written something. Okay. Okay. Then see you in 5 minutes.
Doctor, can I ask you a question?
Yes, Merlin, you can.
What about the first two chapters in the book for the exam? There are examples of drugs. I need to memorize them.
Which are not in the book, in the PPTs, or vice versa?
No, they are in the book.
Mm-hmm.
I need to memorize also the examples in the book of the.
No, most of the drug questions will be from the PPTs, okay? Because in the book I know it's a lot, but the mechanism is better described, so you better read the mechanism and the drugs from the PPT, okay?
Okay, you mean the first three?
First 3 chapters, you mean, or what?
first three chapters you mean?
From the surrender scenes, yes, and
Okay.
for other three from Tripathi.
Okay, so but the examples of the drugs in the book of the first three, I don't need to memorize them, right?
No, you don't.
Okay, because there are
Just
so many.
read them, okay? You won't. I won't give you in this midterm. Definitely not in this midterm. But you
Oh,
might need them in the exam. So for this midterm, you can skip. But for the
oh,
exam, you might still need them. Okay.
okay, okay. Thank you so much.
Okay, you're welcome. Well, I think we better go on because we've got a lot ahead. Okay, people come join us. Yeah, there are big topics in the CNS. I think yes, not logically divided because previous six topics were very small and easy ones. This one is a big one. Okay. So we've got anti-Parkinsonian drugs left and anti-seizure drugs. Okay, I will go on and let others join us time by time. Okay. So this is the chapter 9 in your book, all this sedative hypnotics, alcohol, anti-epileptics, and anti-Parkinsonian drugs, okay? This is just one chapter, but a big chapter, okay? Okay, people are joining and I will just go on then. So the next drugs we can discuss is the anti-Parkinsonian. So first, before that, we should say what are the. This is Parkinson's disease is one of the neurodegenerative disease, which includes not just Parkinson, but also Alzheimer's disease, also multiple sclerosis, and also amyotrophic lateral sclerosis, which is so widely known. And so all of this have the similar peculiarities, like they have progressive loss of selected neurons in the discrete brain areas, resulting in the characteristic disorders of the movement, cognition, and or both of them. So movement is lost with the Parkinson, disease, with cognition, and Alzheimer's, and both of them on multiple sclerosis and ALS. Okay. So let's talk about Parkinson disease. It is destruction of the cells in the substantia nigra, which is located in our brain, which I'm going to show you in the illustration. It results in the degeneration of the nerve terminals responsible for the secreting dopamine, which is then secreted in the overproduction or a relative overactivity of acetylcholine by the stimulatory neurons also might cause Parkinson's disease, because imbalance between acetylcholine and dopaminergic systems also is causing the tremors. This triggers a chain of abnormal signaling, resulting in the loss of control of the muscle movement, and you can see the tremors here. So, Parkinson's disease, it's a destruction of the dopaminergic neurons and the substantia nigra, with a consequent reduction of dopamine actions in the corpus striatum, okay? Parts of the brain basal ganglia system that are involved in the motor control. And rigidity, spasticity, tremors, ataxia might occur with that. Substantia nigra is a part of extrapyramidal system, is the source of dopaminergic neurons that terminate in the neostriatum, and the neostriatum or striatum, it is connected to the substantia nigra by neurons that secrete inhibitory transmitter GABA at their termini in the substantia nigra. So this is how it looks like: dopamine pathway, nigrostriatal pathway. So this is the substantia nigra. This is basal ganglia or the striatum, and dopaminergic signals are just going like this, and we have the lack of dopamine, and it results as the Parkinson's disease. So we've got also secondary Parkinsonism. This is not Parkinson's disease, but the symptoms are like Parkinson, so Parkinsonism. That is why it can be caused after the viral encephalitis or meningitis, and also multiple small vessel lesions might cause Parkinson-like tremors. And drugs like phenothiazine and also haloperidol, inhalatory anesthetic, which we have learned before, those are major pharmacologic actions in blockade of the dopamine receptors in the brain, and they also might produce Parkinsonian symptoms. And these drugs obviously should not be used in the Parkinson's disease patients. So phenothiazines and haloperidol contraindicated in the patients with Parkinson's disease. So the therapy for them, which is the aim of our study, is aimed at restoring dopamine in the basal ganglia and antagonizing the excitatory effect of cholinergic receptors. So this reestablishing the correct the balance between dopamine and acetylcholine. So currently available drugs are temporarily relief from the symptoms of this disorder, but they do not arrest or reverse the neuronal degeneration caused by disease. So they cannot cure the disease, but they can temporarily release the symptoms that disturb the person from functioning properly everyday daily life. Okay. So the first drugs, so we said that substantia nigra, dopaminergic, and in the striatum we've got dopaminergic, which causes neocortex, which is responsible for motor movement, motor activity. And here you can see the dopamine is acting on the substantia nigra, and here you can see that this is the neurons in the substantia nigra, axon, and the striatum. So it means when dopamine is no longer producing, it means acetylcholine production is increased, and also GABAergic is increased. It means we've got the rigid, so balance between acetylcholine inhibitory and excitatory pathways is disturbed, and we got symptoms like Parkinson, and tremors, rigidity, spasticity, and so on. So our aim to treat the Parkinson is what is to give more to how to say, how to say to add as artificial dopamine or dopamine agonist, dopamine receptor agonist, or so to substitute the dopamine we lack in the synapse, and also to block the enzymes that break down the dopamine. For example, MAO and COMT, those are the enzymes that break down the dopamine in the central nervous system, and MAO A also in the periphery, and also to give precursors of the dopamine like L-dopa or the tyrosine in order to produce more of the dopamine, and to block the reuptake as well of the dopamine, and also to suppress the cholinergic actions, so to give anticholinergic. So this is the aim, the logic of the treatment. Okay, the first one will be obviously precursors of the dopamine to give, like levodopa and carbidopa. Those are the metabolic precursors of the dopamine. They enhance the synthesis of the dopamine. The number of neuron disease and the fewer cells are capable of taking up exogenously administered levodopa and converting it to the dopamine. This is at the beginning of the disease onset, they are very productive and effective. But as the disease progresses, it means neurodegeneration progresses. We've got less cells that are able to transform levodopa into a useful dopamine. So at the beginning, they are very useful, but at the end stages or the development further disease stages, not quite the only therapy is not enough. So only symptomatic, and it lasts only while the drug is present in the body. Effect is enhanced by co-administering carbidopa. It is a dopa carboxylate inhibitor that does not cross the blood-brain barrier itself, but also effect is to increase levodopa, which can cross the blood-brain barrier and can be metabolized into dopamine. So this is the picture how you should understand. This is levodopa into dopamine. So carbidopa also blocks the breaking down of this levodopa into dopamine. Also, and entacapone, as well as inhibits the COMT as well in here, which breaks down the levodopa. So they increase the effect of levodopa. Now, the mechanism of action: dopamine itself does not cross the blood-brain barrier, but levodopa is actively transported into the CNS and is converted then to the dopamine in the brain. So this is the mechanism of action. At large doses, the levodopa are required because much of the drug is decarboxylated to dopamine in the periphery. So the resulting side effects include nausea, vomiting, cardiac arrhythmias, and hypotension. So most of the levodopa is broken down in the periphery, and just the part of it is able to reach the central nervous system. So breaking down in the periphery causes side effects like nausea, vomiting, cardiac arrhythmias, and hypotension, or decrease in the blood pressure. So this is nausea, this is the vomiting, cardiac arrhythmias, and hypotension, or decrease in the blood pressure. And the mechanism of action of carbidopa is this is dopa, the carboxylase inhibitor, DDC inhibitor, which breaks down peripheral levodopa, diminishes the metabolism of levodopa in GI tract and in peripheral tissues. It means that more of the levodopa can reach the central nervous system, increasing the availability of the levodopa to the CNS, and lowers the dose of levodopa needed for about 4 or 5-fold. It is 4 times or 5 times less levodopa is needed to achieve the wanted effect. It means the dose of levodopa we prescribe is decreased. It means side effects also decrease. Okay, decreases the severity of the side effects arising from peripherally formed dopamine. And the actions, they decrease the rigidity and spasticity of the muscles, They decrease the tremors as well as the other symptoms of the Parkinsonism. So these are the main effects that these drugs have: carbidopa, levodopa, and also now therapeutic uses. Levodopa in combination with carbidopa is a potent and efficacious drug regimen currently available to treat Parkinson's disease. Okay, approximately two-thirds of patients with Parkinson's disease, levodopa-carbidopa treatment substantially reduces the severity of the disease for the first few years of the treatment. Okay, but mention this one: first few years until the neurodegeneration uh, is severe, because levodopa alone can substitute dopamine, and carbidopa can decrease the necessary levodopa. So in combination, they are very useful at the beginning of the treatment. Patients then typically experience a decline in response during the third or the fifth year of the therapy, because neurodegeneration worsens. It means there are less cells capable of transforming levodopa into dopamine and using it. Okay? Absorption and metabolism, they are absorbed rapidly from the small intestine. The half-life is about 1 or 2 hours. That is why they need to be when they are absent in the body, the effects don't happen. So fluctuations in the motor response is dose related. Suddenly lose normal mobility and experience tremors, cramps, and immobility is also because of that. And levodopa should be taken on an empty stomach, because again it's broken down easily in the stomach, typically 45 minutes before a meal, because neutral amino acids like lysine and isoleucine compete with the levodopa as well in this. Yeah, and the withdrawal from the drugs must be gradual. So gradually should be decreased the dosage, because our body depends on totally on the extracorporeal or artificial dopamine we're given, and if we cease the given the drug abruptly, it means the body is cannot respond well for that, and tremors and all the side effects must adverse effects can explain. Peripheral effects include anorexia, nausea, vomiting. You can see here anorexia because of the stimulation of chemoreceptor trigon in the medulla, tachycardia, and ventricular extrasystoles result from the dopaminergic action of the heart. So it means decreased heart rate, and arrhythmias can be caused for that. Hypotension, as well as the mydriasis, or the dilatation of the pupils by the tube, blood dyscrasias, and positive reactions to COMT. It means immunologic reactions. And also saliva and urine are brownish color because of the melanin pigment produced from the catecholamine oxidation. Now adverse effects on the CNS. These were all the peripheral adverse effects. Now on the CNS, they have visual and auditory hallucinations can be, and also abnormal involuntary movements or dyskinesias, as well as mood swings, it means mood changes, and depression, and psychosis and anxiety can be present as the CNS adverse effect. Okay, I hope you like my gifs. Okay, interactions with other drugs. So it interacts with the vitamin pyridoxine B6, increases the peripheral breakdown of levodopa and decreases the effectiveness. So if the patient is co-administered with the B6, you should expect that the levodopa is decreased the effectiveness of the levodopa. Levodopa and MAO inhibitors like monoamine oxidase inhibitors such as phenelzine can produce a hypertensive crisis caused by enhanced catecholamine production. Okay, this is not Psychotic patients also, levodopa increases psychotic symptoms because we said adverse effects include anxiety, mood swings, and so on. Can cause increase in the glaucoma can be uh, okay, I hope I was not out. Okay, I think, are we good till here? Was my connection lost or are we good here? Can you respond to me? Connection lost for a bit. Okay, I hope it was just a bit. Okay, I'm holding it with my hand because yes, connection is back. Because PC is old. Yeah. So introduction. I will go on then with the interactions. We said with the basic psychotic glaucoma, cardiac arrhythmias, and antipsychotic drugs potentially are not used because they can cause secondary Parkinsonism or Parkinson syndrome, as we said before. So now, another types of drugs we've got selegiline and rosagiline. They are selectively inhibits MAO type. MAO is the enzyme that breaks down the dopamine or levodopa. They metabolize dopamine at low or moderate doses. They don't inhibit MAO type A, which is which metabolize dopamine and serotonin. So type A and type B, they are divided into two types because one of them is active in the central nervous system, one of them in the periphery. Okay, in the increased dopamine levels in the brain, selegiline and rosagiline increase the brain in the brain dopamine levels because they inhibit the enzymes which break down the dopamine and metabolize it. Okay, they enhance the actions of the levodopa obviously when these drugs are administered together. So in combination, carbidopa, levodopa, or selegiline rosagiline can have a triple effect. They little potential for causing hypertensive crisis. This is also important in the consideration. At high doses, the selectivity of the drug is lost, so risk of severe hypertension is increased. Methamphetamine and amphetamine, they are metabolites of the selegiline and rosagiline, and they can cause insomnia. Okay, they are used for to treat depression as well. So this is the mechanism that we discussed before. We said the carbidopa inhibits DDC, while entacapone and tolcapone inhibit COMT, and this one we will discuss further. So wait for me to hear. While selegiline and rosagiline inhibit MAO-B, which is centrally located in the CNS, and MAO-B is not able to break down any more dopamine, so we increase the dopamine in the synaptic cleft. And tolcapone and entacapone we'll discuss further. So rosagiline first. It's irreversible and selective inhibitor of the brain monoamine oxidase type B. It means MAO is no longer able to break down dopamine or metabolize it, and we got a lot more dopamine in the CNS, and we've got less Parkinsonism. 5 times the potency of the selegiline has the rosagiline. It is not metabolized in an amphetamine like substance, so insomnia is no longer the side effect. And now COMT inhibitors or catechol O-methyltransferase inhibitor is also the other type of the enzyme that breaks down. You can see here, I will take you back. COMT that breaks down as well as in the central dopamine as well in the peripheral levodopa. You can see here COMT. So at the periphery, entacapone and tolcapone inhibit the COMT, but at the central nervous system, just the tolcapone is the effective. Okay, centrally effective COMT is inhibited just by the tolcapone. So the mutilation of the levodopa by catechol or methyltransferase or COMT inhibits by COMT entacapone or tolcapone, as I said, leads to decreased plasma concentration of methyldopa. It means increased central uptake of levodopa and the greater concentrations and the dopamine. They reduce the symptoms of wearing off phenomena. It means that seen in the levodopa carbidopa when no longer cells are able to use the existed levodopa and carbidopa and dopamine. So COMT inhibitors reduce those wearing off symptoms. So in the combination with levodopa carbidopa, yeah. And nitrocatechol derivatives that selectively and irreversibly inhibit COMT are also possible to use. Entacapone and tolcapone, as I say, they are orally absorbed and it's not influenced by the food, so it doesn't mean that we should give them particular on an empty stomach. They are bound to plasma albumin. It means that they have limited volumes of the distribution, and tolcapone penetrates the blood-brain barrier. That is why it inhibits the COMT, which is located in the central nervous system and has a longer duration of action because of its permeability. And both are eliminated through the feces and urine. Now, what are the adverse effects of the tolcapone and entacapone? Diarrhea, yeah, and postural hypotension. So in postural hypotension, it means when the patient changes position. It means when from the lying to the prone position or from the sitting to the standing position. Postural hypotension occurs when the blood pressure drops and you got all dizzy and frosty and so on. We, at least once, we all have experienced this type of hypertension. Nausea and vomiting is also adverse effect. Like all the dopaminergic ones can express these side effects. Anorexia as well as dyskinesia and hallucinations, as auditory and visual hallucinations, sleep disorders, and fulminant hepatic necrosis. It means, it means that they are highly hepatotoxic, and the fulminant necrosis is one of the severe adverse effects associated with the use of tolcapone or centrally inhibitor of the COMT. It means the very fast necrosis of the liver and hepatotoxicity. Now, so we discussed the drugs that increase the dopaminergic through dopamine amount through the, for example, precursing it like levodopa, carbidopa, and also inhibiting the enzymes that and COMT that break down or metabolize carbidopa. Now we can increase dopamine through dopamine receptor, not dopamine, but to increase dopaminergic response in order to activate dopamine receptors. We've got dopamine receptor agonists. So as you can understand from my preview, not just dopamine is able to connect with dopamine receptors, but also we have different agonists, which include bromocriptide, ropinirole, pramipexole, and rotigotine. So all these are dopamine receptor agonists, which increase dopaminergic response, but don't increase dopamine. They don't influence the dopamine levels. They have longer duration of action and less risk of developing dyskinesias and motor fluctuations. They're effective in the patient with advanced Parkinson's disease, which have no longer a benefit, which can no longer benefit from the increased dopamine levels because there are no neurons to use it or metabolize it. They're complicated by motor fluctuations and dyskinesias. They're ineffective in the patients who have no therapeutic response in levodopa. They are not useful in the patients. So apomorphine is also used in the severe and advanced stages of the disease as an injectable dopamine agonist. So apomorphine is also dopamine receptor agonist, which can be used as the substitute. Okay, and bromocriptine. So those are here. This slide is very important one. So those are here. They affect the dopamine receptors and increase dopaminergic signal. The first one was the bromocriptine. It is the derivative of the vasoconstrictor alkaloid, ergotamine. Doses increase gradually during a period of 2-3 months. So we can directly go to the higher dose. It can cause hallucinations, confusion, delirium, nausea, and orthostatic hypotension, which is very common. And these kinesias are less prominent than with the previous drugs. Okay, mental condition sometimes happens to worsen, and cardiac problems in patients with a history of myocardial infarction also might worsen. And the peripheral vascular disease like vasospasm is worsening. That's why patients who already have peripheral vascular disease should not be prescribed with the bromocriptine. And it worsens the ulcer as well. Peptic ulcer is a contraindication for the bromocriptine. Pulmonary and retroperitoneal fibrosis. This is an important thing. Fibrosis is one of the side adverse effects of the bromocriptine. And apomorphine, pramipexole, and ropinirole, there are other dopamine receptor agonists. They have non-ergotic dopamine agonists, while bromocriptine was ergotic one. And this is injectable. The only injectable one is apomorphine. Those are rotigotine is transdermal. It means it has a longer duration of action and it can be effective during 24 hours. So once a day as a transdermal patch is available, and it's very effective at the early stages of the disease. It may decrease the dose of levodopa in advanced Parkinson's disease as well. And pramipexole and ropinirole do not exasperate peripheral vasospasm, so the patients who have peripheral vascular disease can be prescribed with pramipexole and ropinirole, while cannot be prescribed with the bromocriptine. And they do not cause fibrosis, which is again linked with bromocriptine. And cimetidine also, which inhibits renal tubular secretion of the organ bases, increases the half-life of pramipexole by 40%. So synergism with that. And amantadine, lastly, it is antiviral drug, which is effective in the treatment of influenza. It is increasing the release of dopamine by blocking the cholinergic receptors and inhibiting NMDA type of glutamate receptor. Glutamate means excitatory. So this is the mechanism of amantadine, which also has anti-Parkinsonian ability. If dopamine release is already at maximum, amantadine has no effect. So if dopamine is already at its peak, we cannot benefit from the prescription of amantadine. And restlessness, agitation, confusion, hallucinations, and acute toxic psychosis or orthostatic hypotension, urinary tension, peripheral edema, and dry mouth are the known side effects of amantadine. They're less efficacious than levodopa, and the tolerance develops faster. So that is why we are discussing it lastly, because it's the last resource. And little effect on tremor, but is more effective against rigidity and bradykinesia, okay, slowed motions. Okay, and we said that Parkinson's disease, one of the causes is the imbalance between cholinergic and dopaminergic pathways. So, in order, if we can no longer increase dopaminergic potentials, we can at least decrease the cholinergic ones. So we can use anti-muscarinic agents like benztropine, trihexyphenidyl, procyclidine, or buperidone Those are they have less efficacy, but they play only a adjuvant role as that's why we're discussing them now. They can cause mood swings, mood changes, produce xerostomia, it means bad smell in the nose, and different taste of the mouth, and visual problems as well. Dryness in the nose, and interfere with the gastrointestinal contraindicated in the patients who have glaucoma, prostatic hyperplasia, and pylori stenosis. Remember these three conditions: glaucoma, increased intraocular pressure, prostatic hyperplasia because it can be more severe, and urinary retention can be severe, and pylori stenosis because they eye peristalsis. Okay, and for patients who already have stenosis, the disease can be more severe. Diverse effects are similar with atrophy, like pupillary dilation, confusion, hallucination, sinus tachycardia or increase in the heartbeat, urinary retention, constipation, and the dry mouth or xerostomia. So this is the part of the slide. They are antimuscarinic receptors, acetylcholine blockage, and they block the bradykinesias caused and tremors by yeah. So these are the summary slide of the side effects. For example, we said that levodopa and carbidopa can cause nausea and vomiting, and also anorexia, and decrease in the body weight, and cardiac arrhythmias, also mood changes, hallucinations, and what is important, stool and the feces and the urine can change into brownish color. Okay, while entacapone and tolcapone can cause constipation and sometimes even diarrhea. You can see here, and tolcapone is very hepatotoxic. It can cause fulminant hepatic necrosis because of its long duration and central activation, and also liver toxicity. And side effects of selagelin and rosagelin include also nausea, vomiting, hypotension, and insomnia. You can see here hallucinations as well, visual and auditory. And we discussed bromocriptine, which could cause not just all these symptoms, but could cause arrhythmias and vasospasm, peripheral vasospasm, and cardiac and pulmonary fibrosis. Okay, cardiac pulmonary fibrosis for bromocriptine, while risperidone, Campixo, all these dopamine agonists, dopamine receptor agonists, can cause cardiac arrhythmias, drowsiness during the day, depression, nausea, vomiting, while anticholinergic have antimuscarinic side effects like constipation, urinary retention, yeah, drowsiness, as well as cycloplegia, means inability to focus because of the dilated pupils, okay, because of the mydriasis. So this is the summary of the side effects. I think it's pretty good to aid you with the visual memory, okay? Visual. So now I have questions for you. Which one of you would like to read the first one? Anyone? Someone? Okay. Are you with me? Okay. Sarah. Okay, I will. I gave you an answer, but important is to read and understand. Okay. Read, please.
Combinations of anti-Parkinson drugs is an appropriate therapy.
We said this.
Choices.
Yes, combination therapy is. We said that carbidopa decreases the amount of levodopa we need to prescribe, and also decreases the side effects. And entacapone in combination, also triple therapy like levodopa, carbidopa, and entacapone at the beginning of the Parkinson are really appropriate. Okay, so remember this combination: levodopa, carbidopa, and entacapone. Okay, they have synergies. Okay. Now the next one for the Yusuf or anyone.
Peripheral adverse effects of levodopa, including nausea, hypotension, and cardiac arrhythmias, can be diminished by including which of the following drugs in the therapy?
I said this one because that is why we use them in combination, so side effects can be decreased. Which one? Carbidopa. So carbidopa decreases the amount of levodopa we need to prescribe, as well decreases side effects. Okay, carbidopa decreases side effects of levodopa. Remember this one. Okay, these questions will make a lot of sense when you're gonna rewatch and read the book. Okay, so next one will be which of the following? Marilyn, do you want to read it? Because Philip's microphone is not working.
Include hypertension drugs may cause peripheral vasospasm.
We said this vasospasm as well as cardiac and pulmonary fibrosis can be caused by bromocriptine. Okay, remember this is important consideration because people who have peripheral vessel disease, who have already cardiac and pulmonary fibrosis, and the risk of developing them increases with the prescription of bromocriptine. So this is the drug which causes peripheral vasospasm. Bromocriptine, remember? B. So these were all the questions for anti-Parkinsonian drugs, drugs. Now last subject, and we've got half or 20 minutes, which we're gonna go through fast. This is the last one, but not least important. This is epilepsy. So epilepsy is an assortment of the different seizure types, and the syndromes originated from the several mechanisms that have in common the sudden, excessive, and synchronous discharge of the cerebral neurons. So the discharge or the excitement of the neurons, which takes place at the many locus at the same time, can cause the seizures. Okay, so imbalance between inhibitory and excitatory pathways causes the seizures. So this, as you can see here, we have many types of excitatory pathways. Here you can see sodium influx, calcium influx causes the glutamine to convert into synaptic cleft. It can join the NMDA receptors, can join AMPA receptors, and can exhibit their excitatory potential, and also can join the calcium channel T type, and also we've got here. So the excitement, so it means the blockage of this sodium channels, blockage of this calcium channels, as well as this NMDA receptor, AMPA receptor, and also T-type receptors can block the seizures, while increasing the GABAergic, it means increasing the inhibitory potential, can also benefit from quitting the seizures. So it means the GABAergic potentials here, GABA retake if it's blocked by GAT, or GABA breakdown if it's blocked, or GABA receptors are activated. It means the inhibitor potentials might win against the excitatory, so it means the seizures can be quitted. So you will see that when we discuss the therapy. This is yeah. So seizures are accommodated or accompanied with the loss of consciousness, abnormal movements, which are called tonic-clonic movements, or myoclonic, atypical or odd behavior, because some of the patients have aura. It means they have feeling that the seizures is coming occur, and also distorted perception during the trance, or this is this type of the seizure. One can kill a person and without remembering it. is like this. So 3% of individuals by the time they are 80 years old have at least once in a lifetime had a single seizure. So 10% of the population will have at least one seizure in their lifetime. And globally, epilepsy is the third most common neurologic disorder after cerebrovascular disease and Alzheimer's disease, so the third one in a row. And also, one of when I say the 10% of population have at least one seizure, I mean febrile seizures as well, because all of the children might have experienced this one. When temperature raises more than 38 degrees of Celsius, a child can develop a seizure. So 3% is one. Okay. This is Alexander the Great. This is Caesar, Julius Caesar, even Napoleon, Nostradamus, and
We must know.
No, you shouldn't. Just this for you. And this is the side information. The Byron, Lord Byron, and Van Gogh, all of them were diseased with epilepsy. So I want to know that this is the disease does in somehow you can imagine that the disables people, but all these famous people had this disease, but managed to live their lives very fully and very effectively, because we all know their names. Oh, and the queens as well, and this is the actors, and Elton John also have epilepsy, but they are living their lives at the fullest. So the causes of the seizures in the children can be trauma, because they are very, how to say, for example, traumatic experience during labor, intracranial hemorrhage, ICH, during the traumatic labor, cerebral infections, febrile temperature can cause the trigger the seizure, and hypoxia also. A decrease in the oxygen levels in the brain can cause the seizure in the children, because children are very prone and very sensitive to this, and because their brains are not developed fully. Yeah, hypoxia, yes, also one of the reasons of seizures in the children. While in adults, most of the common cause is the tumors or the brain lesions or brain, cancer can be the cause of it, because the zone in where they are located can be peripheral edema. You can see around the tumor, and it is the trigger zone, sensitive zone, that might cause seizures. Also, traumas and alcohol and some drug abuse can be the reason of the seizures. Yeah, this one also. And in elderly people, can be cerebral vessel pathologies like stroke, or atherosclerosis. Stroke, you can see hemorrhages, can be the most common reason of the seizures. So classification we've got here in your books as well. You're gonna read them. We've got partial and generalized seizure. Partial, it means just one hemisphere of the brain is involved in the seizure, and just and can be without losing this consciousness. Okay. While generalized seizure, it is both of the hemispheres are included in the malfunctional or mal excitement in the conduction of the impulses, and most commonly consciousness is also lost within the seizure. You can see one or the neurons, and many neurons are in generalized seizures. You can see one hemisphere involved. You can see both of the hemispheres involved. So tonic-clonic seizures are the examples of generalized seizures, and clonic contraction of the seizures. And absence also is the type of seizure which is not expressed with the certain movements of the extremities, but the loss of the eyes are like they're like see-through. For example, if you ever have skipped your bus stops, you might have an absence seizure, because you don't remember the period of time So it means you have lost consciousness, you have in you, but this is a possibility. Myoclonic seizure is a type of seizure, myoclonic discharges and contractions of the muscle. Febrile seizure is also exam status epilepticus, which I have previously said. This is the series of the seizures. In between the series, the consciousness is not regained. So the patient is lost consciousness during the longer, prolonged period of the time, and these can be lethal and they endanger the life of the patient if not anti-epileptic drugs are not given and the status epileptic not ceased immediately. Okay, I think something happened to my PC. So the next one, this is illustration drawn by the person who is diseased with epilepsy. So triggers, I wanted to discuss triggers. What can trigger the seizure? Insomnia or the sleep deprivation can cause the trigger. An absolutely healthy individual as well, and a person who is prone to epilepsy as well. The sleep deprivation can they can use this one can as diagnostic tool as well. Sleep deprivation is the trigger of the seizure, and also diet. Some of the diets can be, or the hunger can be cause of the seizure. Bright flickering lights, like in the disco, can be cause of the seizures and are used as a diagnostic tool to provoke the seizure in order to register it in the EEG or electroencephalography. And the hot tub can be the cause. Hyperventilation or stress can be the cause, as well as along with the alcohol abuse and some of the drugs abuse. And drugs even that we are prescribing can have potential to cause the seizures. So what are the diagnostic tools? This is neurological center test, blood test, EEG, which is electroencephalography. This is the digraph registering of the seizures. MRI, PT is have to exclude the lesions in the brain and to exclude the tumors or hemorrhages and traumas and so on. So blood test, EEG, you can see like this. This one is EEG. This one is CT. This is PET. And what are the types of treatment we've got for epilepsy? The first one is obviously pharmacology treatment or conservative treatment, which is called. And the other one is a surgical one, which includes vagus nerve stimulation and deep brain stimulation. If you are interested, I can discuss them further. Just shortly about this. This means that to implant the vagus stimulation rather than to enhance inhibitory pathways, and DBA, it means to stimulate the parts or to initially to indicate the parts of the brain which exhibit abnormal activity, then to stimulate with the electric discharge and to to stop it, switch it off. Okay, but this one is evolving nowadays. And these are all the drugs. I know this looks confusing, but it will make a lot of sense after you read the book and rewatch my video lesson or the tutorial or lecture. So we need to block sodium channels. We can use topiramate and carbamazepine, lamotrigine, all these drugs listed here. In order to block the glutamate or excitatory neurotransmitter exocytosis, we can use levetiracetam. We can block NMDA receptors and AMP receptors as well with the phenylbutamate. And this one also, topiramate also blocks AMP because we have yellow here. And valproic acid and zonisamide block calcium channels, and GABAergic inhibitory GABAergic pathways are activated by barbiturates and benzodiazepines, which can be used for anti-seizure drugs. And tiagabine can block KT, which is retaking GABA and decreasing the GABA amount in the synaptic cleft. And vigabatrin can block GABA transporter or Bragg enzyme that breaks down GABA as well. So this is the logic of the treatment. Now we will discuss the side effects shortly. So carbamazepine and oxcarbamazepine can decrease the sodium levels and can cause hyponatremia. So you should check all the time electrolyte balance with the patient who is prescribed these two drugs. Vigabatrin can cause blurred vision or decrease the vision, decrease the inability to focus. While like this psychoplegia can be caused by lamotrigine and phenytoin. Gingivitis can be caused by phenytoin and lamotrigine, as well as hirsutism. You can see excessive formation of excessive hairiness in the females. While every type of anti-epileptic drugs at some point can cause sedation and dizziness and the decrease in the cognition as well. Gabapentin and pregabalin can cause peripheral edema, while valproic acid with the gabapentin and pregabalin can cause the weight gain as well. Valproic acid and fulvamate can cause liver toxicity, and fulvamate can cause aplastic anemia as well. While topiramate and zonisamide have vice versa than valproic acid, they can they cause the weight loss, and also some cognitive dysfunctions are possible as a side effect of topiramate and zonisamide. So this is just summary, and we will discuss them one by one. I mean, you're gonna read them one by one because we've got only 5 minutes left. So we are discussing benzodiazepines, which we have first discussed as sedative hypnotics, but they are very good anti-seizure drugs because they increase the GABAergic activity. It means inhibitory activation is increased. They can be caused to seize the seizures. Carbamazepine as well, it's effective for the seizures and causes hyponatremia and rash. Etosuximide, it's effective for T-type channels. This is all the full description of the illustrations we saw before. So you can read this one and go back to the illustration in order to understand them well and memorize with your photo memory, okay? Gabapentin, lacosamide, lamotrigine, which is good for the Lennox-Gastaut syndrome. This is the absence seizures, and this is the very severe seizure in the children, which is resistant to many types of anti-epileptic drugs. Okay. And we've got levetiracetam and oxcarbamazepine, which used in children as well as in adults. And we've got phenobarbital, phenytoin, phosphenytoin, and pregabalin. All this you're gonna read by yourself because the mechanism is already explained. And furosemide, pregabalin, topiramate also. Topiramate is important to remember because it's a partial primary. It's used for the partial and primary generalized epilepsy, and lamotrigine increases topiramate concentration. So lamotrigine and topiramate together have more enhanced effects, but they can cause renal stones and glaucoma, oligohydrosis, and hyperthermia, and have also been reported. While valproic acid is very hepatotoxic and can cause teratogenicity, it means the potential birth defects, okay, with the fetus, abnormalities of the neural tube defects, and so on. So zonisamide can cause kidney stones, and oligohydrosis can be was reported with that drug. Now, the question for you, and we will just end it. Who wants to read? I know it's a lot, but
A 9-year-old boy is sent for neurologic evaluation because of episodes of apparent confusion. Over the past year, the child has experienced episodes during which he develops a blank look on his face and fails to respond
Oh, yeah. Yeah, this
to
is
questions. Moreover, it
absent. Yeah.
appears to take several minutes before the boy recovers from the episode.
Mhm.
Which one of the following describes his patient's seizures?
It looks like absence, which I described, but you should take in consideration it takes several minutes. It means absence is short, very short, for like a minute, but several minutes it is a complex partial seizure. Okay, this is this description of complex partial seizure. Okay, remember. It might be in the next midterm, so you better remember it. Okay, this the next question.
Which one of the following therapies would be appropriate for the patient described in the above question?
So for the complex partial seizure, which drug can we use? So I have missed all the usage, so I will just skip to the answer. Carbamazepine is very useful for the complex partial seizures, and you will read and you will get one. Okay. The next one. So again we have the same patient, Marilyn, or anyone
The
who wants
patient
to.
described in question 1 was treated for 6 months with carbamazepine, but recently has been experiencing breakthrough seizures on a more frequent basis. You are considering adding a second drug to this patient anti-seizure regimen. Which of the following drugs is least likely to have a pharmacokinetic interaction
Mm-hmm.
with carbamazepine?
Of carbon. So I will give you the answer. This is levetiracetam. It enhances the properties of and pharmacokinetic interaction with the carbamazepine. Remember, levetiracetam and carbamazepine together, okay, exhibit more anti-epileptic function. So I advise you to use your brains, read the PPT. Thank you, thank you, thank you very much. So this is the one of the longest PPTs I have ever made. It includes 100 slides, but you're gonna see in the book as well. It is a big chapter, chapter 9. Okay, read, then rewatch our tutorial. Okay. So I think I've got a question here. Yes, okay. So this is a big chapter, but really important one. And as you can understand, it's a lot difficult than the previous 6 chapters. So just don't waste your time. Along with the preparation for the midterm, read the chapter as well. Okay. I know it's difficult, but after that, it will be even difficult if you miss this one. Okay. Okay. I hope everything was clear with it. Do you have any questions concerning this topic? Okay, I'm waiting. No, thank you. Okay, thank you. Thank you for your attention and attendance. Thank you for always being here, all of you. uh, okay, I hope you are already safe back to your countries, to your homes. Stay safe, stay home. Say hello to your families and study. Okay, don't waste your time study. Okay, this virus and this era in our life is gonna end finally. You're gonna want to pass the exams. Okay, and that is why you have to study. Okay, we all study. Okay, you're gonna read it and then because it's the difficult part, as I said. Okay, thank you again and bye bye. I'll just quit recording. Goodbye. Have a nice day. Have a nice week. And we're gonna meet with you on Saturday and we're gonna continue discussing drugs affecting CNS. Okay. Bye bye. See you next tutorial.